بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. Dr. حمدي إحسونة, Head of the Rheumatology Department, Benghazi Medical Center, University of Benghazi, Consultant Rheumatologist and Teaching Staff Member, Faculty of Medicine, Benghazi. في البداية أرحبوا بالإخوة الزملاء والطلبة اللي حاضرين معنا اليوم. Our talk today are going to introduction to the rheumatological examination and history taking. First, we'll start with the history, how to take rheumatological history and practical approach to the history. Rheumatological history divided into three parts. Okay, first part is what we call as an articular history. Second part is an extra-articular history. Third part is the systemic features. The first part of the articular history depends upon number of the joint involvement. As we know that all the rheumatic diseases, they are sharing joint involvement. All autonomical disease, they have sharing the same joint involvement. First, you are going to go to ask about the onset of the joint disease. Okay, onset, we are dividing into three parts. Number one, we have a dramatic onset, that the pain scale is going from 0 to 10 within a seconds. It's an explosive onset or a dramatic onset. Okay, the patient has nothing, no symptomatology. Within a few seconds, the patient has a maximum pain intensity. And this is characteristic what's so-called is a gout disease. The second onset was so-called a sudden onset. Okay, sudden onset that the pain start and developing over hours. Okay, over hours on the same day. It's going to the same day of build up intensity of the pain, build up over hours. And this characteristic of the septic arthritis. The third part is a gradual, gradual that the pain intensity is increasing over days. And this characteristic what's so-called rheumatoid arthritis. The second part of the history, you need to ask about number of the joint involvement. We are dividing into three parts. Number one, monoarticular, and there is one joint involvement. It's called monoarthralgia, monoarthritis, or monoarticular involvement. The second, we have a number from 2 to 3. If the patient complaining of 2 to 5 joint involvement are called as oligoarticular or polyarticular involvement. More than 5 joint involvements was so-called as a polyarticular involvement. Okay. Third part, you need to ask about the swelling. The patient has only pain to the joint. This is what's so-called an arthralgia. The patient has a pain plus swelling, we call an arthritis. Okay, so each one has its own differential diagnosis. We have a monoarthralgia, we have a monoarthritis, we have oligoarthralgia, oligoarthritis, polyarthralgia, and polyarthritis, and each one is characteristic for some pathology. The fourth question you need to ask about the onset. Okay, is it an acute or is it chronic? If the patient has the complaint less than 2 weeks in duration, we call it an acute onset. If he has a duration of the disease onset more than 2 weeks, patient complaining joint pain, more than 2 weeks, this is a chronic. And this is a very important differentiating point. For example, if a patient has one joint involvement, is an acute arthritis, acute monoarthritis, one joint involvement and acute onset, has this characteristic for gout and characteristic for septic arthritis. If the patient has a chronic onset, like patient has a chronic arthritis, has monoarthritis, one joint involvement for several months, this is characteristic for tuberculosis. So very important differentiating point. Number 4, we are going at which joint is involved. Is it the large joint involvement or small joint involvement? Large joint involvement meaning that most large joint, meaning hips, knees, ankles, and shoulder, elbow, this large joint. Small joint meaning hand joint and feet joint. Every involvement, there is a characteristic disease entity. Small joint involvement are more common in patients with systemic lupus erythematosus, more common in patients with rheumatoid arthritis. Large joint involvement is characteristic that the large joint involvement is according to the age. In children age from 5 years to 15 years, characteristic for rheumatic fever. This is commonly affecting the large joint. Okay. In elderly large joint involvement, this is most characteristic for the osteoarthritis. Most characteristic for osteoarthritis. Involvement of the small joint plus large joint involvement characteristic for rheumatoid involvement. The acute polyarthritis characteristic systemic lupus erythematosus, while chronic polyarthritis characteristic rheumatoid arthritis. It's very important to ask. The course of the joint involvement is very important. Course of the joint involvement is very important. Is it a remitting course, is a progressive course, or a stationary course? The progressive course that the patient having pain increasing day after day, the patient is not improvement unless receiving treatment. This is characteristic for rheumatoid arthritis. And we have a remitting course that the patient start to have severe pain and swelling, and the pain and swelling subside within a few days with the treatment and without the treatment. If the patient has acute arthritis, within 3 days patient get improved. This is a remitting course characteristic lil gout disease. It's very characteristic of gout disease, what's so-called remitting course. The second, we have a stationary course that the patient develop the pain and the swelling. The pain and swelling is persistent over days. There is no increase in intensity and there is no remission. And this is characteristic for septic arthritis. So the progressive course is very important, and the remitting course very important for differentiating each point. It's very important to differentiate between all the involvement of the joints. The other characteristic point, what we are going to ask about the other joint. We have a peripheral joint and we have a systemic joint. Systemic joint, we have what's so-called the sacroiliac joint, and we have the other joint, what's so-called, there is a spinal involvement. Very important entity, to ask about the spinal involvement. How to ask about the spinal involvement? Spinal involvement, that the patient has low back pain, has low back stiffness. If the patient has a low back, you should ask about the low back pain. Low back stiffness indicate that the patient has spondylitis. If the patient has spondylitis, it's a very characteristic feature for differential diagnosis. Involvement of the spine exclude diagnosis of rheumatoid arthritis. Rheumatoid arthritis doesn't involve the spine. If the patient has spondylitis, this is characteristic for what's so-called entity of diseases they called spondyloarthropathy. And spondyloarthropathy is a group of heterogeneous diseases like psoriatic arthropathy, ankylosing spondylitis, and inflammatory bowel disease, what's so-called enteropathic arthritis. All these groups are sharing with a spinal involvement. The other joint you need to ask about is the sacroiliac joint. Sacroiliac joint is a deeply seated joint. It's a deeply seated joint. Sacroiliac joint, in the history you need to ask about, is the patient have a difficulty in initiation of the movement, in patient difficulty in standing and sitting. Patient unable, has difficulty and pain while he's standing, and has a pain and difficulty while he's sitting. Okay, so this is characteristic for sacroiliac involvement. The other point, that patient has a persistent low back pain, and this is characteristic for sacroiliac joint. Involvement of sacroiliac joint characteristic of spondyloarthropathy. So this make that diagnosis spondyloarthropathy is the number one diagnosis. Rheumatoid arthritis doesn't involve the sacroiliac joint. If the patient has a sacroiliac joint, it exclude rheumatoid arthritis. Patient has a spinal involvement, exclude rheumatoid arthritis. Okay, so this is what's called the articular history. The second part is the extra-articular history. As we know that rheumatoid arthritis and SLE, this is a chronic multi-systemic. By definition, they are a multi-systemic diseases. They involve all the system which include connective tissue diseases, what's so-called connective tissue. As we know that the connective tissue is the most abundant tissue into the body. They present most of the organ. And the CNS and heart, lung, kidneys, blood vessels, and eyes, skin and mucous membrane, and joint, all including they have a connective tissue. So all these systems are more prone to be involved in these diseases. They are multi-systemic. So you need to take an extra-articular history. Extra-articular history, to simplify the history, should start from the top to the bottom. Starting number one by the most common organ involvement was skin. You should ask about the skin involvement. How to ask about the skin involvement? Ask about evidence of presence of any rash. The patient has rash. The important point about the rash, number one, you should ask about the color of the rash. Okay, if the color is red, this is more characteristic for systemic lupus erythematosus. If the color of the rash is violaceous color, with violaceous color, لون قرمزي, this is characteristic dermatomyositis. Characteristic dermatocyte. Number one, you need to ask about the color. Number two, you should ask about the site of the skin rash. Skin rash on the face, this is most likely due to the systemic lupus erythematosus. And the rash on the face could be due to the dermatomyosites. Differentiate between systemic lupus and dermatomyosites by the color. Skin rash of systemic lupus erythematosus is red. A skin rash of dermatomyositis violaceous into violaceous color. Color is violaceous color. The second site, very important, other than the face, اللي هو arms. Patient has a skin rash over the arms and forearms. Presence of rash over the arms and forearms are characteristic for systemic lupus erythematosus. Okay, the skin rash involving the extremities into the lower limb. Patient has bilateral skin rash over both lower limbs are characteristic for what's so-called vasculitis. Characteristic for vasculitis. A presence of skin rash over the trunk of the chest, abdomen, and back are characteristic what's so-called Still's disease. So site of the rash is very important. The other point to ask about the skin rash, is it pruritic or non-pruritic? If the patient have itching with a skin rash or none. Patient have a pruritic skin lesion that suggests that the patient has some form of dermatitis. The patient has some form of dermatitis, which has been seen in cases of dermatitis herpetiformis. The painless rash is more characteristic of cili. A cili rash usually is a painless skin rash. So distribution of the rash very important. The site, pruritus, non-pruritus, and the color. Very important differentiating point, the skin rash. The second organ involvement, we have a mucous membrane involvement. Mucous membrane involvement meaning that the patient has an oral ulcer or genital ulcer. So you need to ask the patient if the patient has an ulcer into his mouth. So we have a 5 site into the mouth. You need to ask, does the patient have an oral ulcer over the lips, gums, buccal mucosa, over the tongues? This is all 5 sites you need to ask about the oral ulcer. Second, you need to ask about genital ulcer. Presence of oral ulcer are characteristic of systemic lupus erythematosus. The most common cause of oral ulcer is the systemic lupus erythematosus. The second common cause is the Behçet disease. Genital ulcers, commonly due to the Behçet disease, some form of vasculitis called Behçet disease. Presence of recurrent oral and genital. In the same patient, top on the list is the systemic lupus erythematosus. The second diagnosis is going with the Behçet disease. But mucous membrane is very important part in the history. Other organ involvement is the kidney involvement. Okay, kidney is the most important organ involved in the chronic systemic autoimmune diseases. How to ask about the kidney involvement? Kidney, we have 2 pathology. We have a nephrotic pathology and we have a nephritic pathology. Nephritic pathology characterized by proteinuria leading to hypoalbuminemia leading to the swelling. So you should ask the patient about the presence of any ankle swelling or presence of periorbital swelling. The second pathology in the kidney involvement is the nephritic. We have in the pathology there is a nephritic syndrome. Nephritic characterized by hematuria. You should ask the patient about the color of the urine. Does the patient have red urine or no? If the patient have a red urine, so there is a raised possibility that there is a glomerulonephritis. So renal involvement is very important organ to be asked about. In others, we have other organ involvement, they are lung involvement. Lung involvement and the systemic rheumatic diseases, they are common pathologies. The commonest pathology is the pleuritis and the pleural effusion. You need to ask about the pleuritis by asking the patient about the presence of any chest pain. Pleuritic chest pain. Pleuritic chest pain usually is a peripheral chest pain. Ask the patient, does he has a pain in the peripheral part of the chest? And this pain is increasing by taking breathing. Okay, ask the patient, does his pain is increasing intensity by taking deep breathing? So pleuritic chest pain, very important part. The second part is a dry irritating cough. Dry irritating cough with the pleuritic chest pain suggests that the patient has pleural involvement. The other organ involvement you need to ask about is the blood vessel involvement. Very important, blood vessel involvement. So we have several forms of blood vessel involvement. Number 1, the patient will have a vasculitic skin rash. You should ask about the skin rash, and this rash usually involving both lower limbs. A presence of persistent bilateral red skin rash over both lower limbs. Vasculitic rash characteristic over both lower limbs. Second, about vascular involvement, you should ask about the cold hypersensitivity. Most of the systemic autoimmune disease, the patient have a cold hypersensitivity. Cold hypersensitivity is an integrity which has several stages. In the mild stage, I'm going to progress to severe stage. The first stage that the patient on exposure to cold, he has a change in the color of hands or feet. They change the color to the blue color. The hands becomes blue and discoloration and exposure to cold. Severe form of cold exposure was so-called Raynaud's phenomena. What characterizes Raynaud's phenomena? We should have all the color involvement. Raynaud's phenomena, the patient should have 3 colors at the same time. The patient, number 1, patient will have 3 stages, 3 pathology. No exposure to cold, the patient have a vasoconstriction. The hands going to be purple in color. A second, the patient will go into the stage of the intense vasospasm, and the hands become so pale, like a ischemic limb. Within a few seconds, the patient will have a reactive vasodilatation, and the hands become red. But we have 3 color. If you don't say that the patient has a Raynaud's phenomenon, let's say passing through 3 stages. First one is a blue color, the second is white, the third is red. So 3 stages suggest the patient has a Raynaud's phenomenon. If the patient has a Raynaud's phenomenon, very characteristic, the commonest disease causing Raynaud's phenomena is the scleroderma. And we so-called the Raynaud's phenomenon as a pre-scleroderma stage. So very important to ask about the blood vessel involvement. Third part of the blood vessel involvement was so-called intermittent claudication. Intermittent claudication. Intermittent claudication, there are the criteria to define, to differentiate from the myalgia and the muscle cramps. In intermittent claudication, the patient was in the action movement. The patient was walking, he's moving. Suddenly, the patient has a severe pain, and he is unable to complete the action. Patient unable to complete his walking. Patient is going to sit with a severe pain. After a few seconds, the patient can go again and continue the function. You have a differentiation between the myalgia, muscle cramps. Muscle cramps, the patient has severe pain but can continue the movement. In intermittent claudication, there is complete abstinence, complete inhibition of the movement. But severe pain and unable to complete the movement, and this suggests that the patient has some form of vasculitis, some form of pathology, the microthrombi. This microthrombi, there is ischemia, and the patient has the spasm and able to complete. This intermittent claudication. The other system involvement, the systemic rheumatic disease, is the CNS involvement. We have the central nervous involvement, and we have a peripheral nerve involvement. CNS involvement, the most common representation is that should ask the patient about history of convulsions. So we have diagnosed several cases treated as an epilepsy, and we found that the underlying pathology is the systemic autoimmune disease. So should ask about the history of convulsions. The second pathology that the patient with systemic rheumatic diseases or autoimmune disease, the patient may develop a stroke. So stroke in young age, especially stroke in young female, you should exclude systemic rheumatic disease as the cause of the young stroke, like in young female without any risk factor. Young female, no diabetes, no hypertension, she is not smoker and she has a stroke, should exclude systemic rheumatic disease. Convulsions, number 1. Number 2, if the patient have evidence of CVA, cerebrovascular accident, with a hemiplegia or monoparesis. The other system involvement is peripheral nerve involvement. Peripheral nerve involvement, that the patient will complain of paresthesia, numbness, and tingling sensation, involving both hands, common site, hands and feet. Should ask the patient if he has any history of paresthesia, numbness, or tingling sensation involving both hands and both feet. It suggests that the patient has a peripheral nerve involvement. The other important point is gastrointestinal involvement. So most of the chronic rheumatic diseases, they are an autoimmune diseases, and they got involvement association with an autoimmune involvement of GIT, like autoimmune hepatitis. Patient may have jaundice, may have a patient. Should ask about the liver involvement. Any patient with suspected systemic autoimmune disease, like systemic lupus erythematosus, rheumatoid arthritis, should ask about the jaundice. Does the patient have developed any jaundice? Second, does the patient have any evidence of pruritus? So jaundice, pruritus suggests that the patient may have an hepatic involvement in the form of autoimmune hepatitis. The patient has hepatitis, and this is seronegative, it's not a virus, seronegative, you think of autoimmune hepatitis. So ask about jaundice and ask about the evidence of any pruritus. This is due to the age involvement of the GIT. So this is the extra-articular history or part of the systemic history. Third part of rheumatological history was so-called the systemic symptoms. We have 5 symptoms, what are so-called systemic symptoms. Anorexia, weight loss, fatigability, sleep disturbance, and low-grade fever. There are 5 symptoms that are called systemic symptoms. The presence of at least 3 out of 5 suggests that the patient has a systemic autoimmune disease. Patient has unexplained low-grade fever, unexplained anorexia and weight loss, sleep disturbance, and easy fatigability, and with joint involvement. This is suggestive that the patient have a systemic disease. Significance of these systemic symptoms, this indicate that the patient has an active disease. These systemic symptoms are due to the release of what's so-called inflammatory mediators, like interleukin 1, interleukin 2, 6, and 8. So interleukin release, interleukins are vasodilators and leading to what's so-called systemic symptoms. Present systemic symptoms in the patient with joint involvement suggest an active disease. So this is in brief how you are going to take a rheumatological history.